My name is Brittany Crawford and I am a kindergarten teacher, and my job is super busy, super active. So it requires me to be constantly moving. I'm standing on my feet all day. I'm up at the front of the room. I'm down on the floor at the back of the room. So it's exhausting, and especially with lipedema, because I'll come home from work, my feet are throbbing, my legs are full feeling, just really uncomfortable and very sore and very tired. I'm here to share my story and to help spread awareness about this disease so that maybe I can help even just one woman. I woke up after going to therapy the first time. I woke up the next morning and I had ankles for the first time. So I was running around the house telling my whole family, I have ankles, because I hadn't seen them in so long. And so those visits timed out with insurance. And from there, I was able to get my FlexiTouch machine. That was a turning point for me, because having that machine allowed me to do my own therapy in my own home.
Hello, everybody, and welcome to our webinar this evening titled Recognizing Lipedema and Treatment Options for the Patient. Is appropriate given that this is Lipedema Awareness Month, and we have an all-star team here together that's going to be covering some interesting topics. Steve Dean, Julie Green, Thomas Wright, and myself. For anybody has any interests, any questions, please submit them at the Q&A button at the bottom of your screen. And for those who would like to have access to this after the webinar, it will be recorded and will be available at the Tactile Educational website in order to listen to it again. So with that, I'd like to hand it over to Steve. Steve, if you can share your screen, and we're going to kick it off with the first talk.
All right. Okay, you see my screen okay?
Yes, we do, Steve.
All right. All right, so I was asked to speak on the clinical manifestations of lipedema, the basics, the overlooked, and the difference between lymphedema. Disclosure, big surprise here. All right, let's start with the basics. Well, not a lot has changed since this seminal article was released in the Mayo Clinic in 1951, where they identified 6 cardinal clinical features of lipedema, which included the following: almost exclusively female. The swelling is bilateral and symmetrical with foot sparing, as seen here. A component of minimal pitting, orthostatic, or dependent edema at the end of the day, hence the term lipedema. 90% of these patients have significant pain and or tenderness on pressure. 80% have a tendency toward easy bruising, spontaneous hematoma, and frustratingly, persistent enlargement of extremities after weight loss. So the lipedema patient has a very unique somatotype, as seen here. They have this symmetrical, disproportionate fatty limb swelling, which spares the torso, as you see here. So there's a mismatch, if you will, between the size of the torso and their lower extremities. These people often have a pear-shaped configuration to their body. Now, if you'll notice here above the arrow, there's a cicatrix or a scar. This patient underwent a previous gastric bypass surgery, lost over 100 pounds, and unfortunately, her legs never simply improved. You can't starve lipedema. It's a diet-resistant fat. So here are examples of early or classic, or what we call pure lipedema, where the feet are spared of permanent foot swelling. And you can see over here on the right-hand side, even despite advanced stage 3 lobular lipedema, no significant foot swelling. The ankle cuff sign, a unique phenotypic feature of lipedema, where this symmetrical disproportionate fatty limb swelling abruptly terminates above the level of the malleoli, as seen in these 2 highly illustrative cases. Also note the easy bruising and 80% from the associated capillary fragility. There are several phenotypes of the distribution of leg swelling and lipedema. The most common lower extremity phenotype will be the full leg type, where the swelling begins in the hips and it terminates at the ankles, and the ankle cuff sign, as seen here. Now, the second most common type you will see is the upper leg type, where the swelling begins in the hips and it terminates at the level of the knees, as seen in these two incredible examples. These legs are said to have a Jodhpur pants type appearance. Now, let's talk about the overlooked. Talked about the basics. I find the overlooked even more fascinating than the basics. And although you understandably concentrate on the legs when you see these patients, with a careful physical examination, you'll note that 80% of your lipedema patients have arm swelling. The most common phenotype will involve the upper arm. It just extends from the shoulder to the elbow. A lesser common type, or lesser frequent type, would be the full arm type, where the swelling begins in the shoulders and it terminates at the wrist in a wrist cuff sign. So it parallels the ankle cuff sign that you see in the lower extremities. Often overlooked manifestation in lipedema. Now here I'm showing you the sharply well-defined concave retromalleolar sulci of a normal ankle. But in early, this is often overlooked sign in lipedema, you'll note here that you've lost that concavity because of associated fat deposition within the retromalleolar sulci. Very characteristic, often helpful feature in these early cases where you're not sure if they have lipedema or not. Now, if you haven't already downloaded this article, I encourage you to do so. The standard of care for lipedema in the United States, 85 consensus statements. I think the most important is 1.1, which is lipedema should be regarded as a loose connective tissue disease versus a disease of just adipocytes or fat. Loose connective tissue disease are associated with dysfunctional collagen and elastin fibers. And because lipedema is a connective tissue disease, it should not be a surprise that at least 50% of these patients have associated joint hypermobility, as you see in these four highly illustrative examples. In this one paper, half the patients had a pathological Baden hypermobility score of 5 or greater. Now let's zoom in on this right here, an underappreciated or overlooked physical manifestation of lipedema. In addition to the thumb apposition to the thumb, what do you notice about the skin here? It's very thin, it's soft, it's translucent. Look how easy it is to see that vein. Soft, translucent skin, overlooked manifestation. Now, of interest, here's the diagnostic criteria for the connective tissue disease hypermobile Ehlers-Danlos syndrome. Look at one of the clinical characteristics. Unusually soft or velvety skin. Because of the associated connective tissue disease mediated joint laxity, a significant portion of your lipedema patients manifest knee pain. They have genu valgum or knee knock or knock-knee appearance, as you've seen here. Genu recurvatum, or more than 10 degrees hyperextension of the knees, as seen here, often overlooked. Also, because of the connective tissue disease joint hypermobility, a significant portion of these patients manifest foot pain with pes planus, or very flat feet. And if you look at them from a posterior view, in addition to filling of the retromalleolar sulci, note the ankle pronation as well, often overlooked in lipedema. Because of the connective tissue disease mediated dermal laxity, these patients have pesogenic papules. Upon standing, you'll note these fatty compressible deposits along the calcanea. Note, and back to our checklist of diagnostic criteria for hypermobile Ehlers-Danlos syndrome, bilateral pesogenic papules of the heel, often overlooked in your lipedema patients, because you got to turn around and look from a posterior view. Now, if you look at the signs and symptoms in lipedema, they eerily parallel the extra-articular manifestations of joint hypermobility syndrome, such as your hypermobility spectrum disorders or hypermobile Ehlers-Danlos syndrome. Both of these disorders are chronic pain syndromes, or chronic fatigue syndromes, they're associated with irritable bowel syndrome, chronic headaches, pelvic floor laxity with associated frequent urination, up to 2/3 of your lipedema patients. One that I think is always very interesting in these patients, the associated cardiovascular dysautonomia, which leads to recurrent orthostasis or POTS, Raynaud's phenomenon, acrocyanosis. In fact, often overlooked. In addition, when you're examining these patients, if you feel the temperature of the skin, you'll note that they have associated cutaneous hypothermia, very cool skin. Now, this cool skin often occurs in association with this reddish purplish discoloration that you see in the lower extremities, also known as erythrocyanosis. So you tend to focus on the swollen legs, but look at this discoloration. It involves the feet and extends all the way up into knees in both these patients. Again, if you palpate the skin, it's palpably cool cutaneous hypothermia. It's from the associated dysautonomia. From the associated dysautonomia, they also get this reticular fishnet-like appearance of their skin, noted or referred to as livido reticularis. That skin is definitely palpably cool, and it also often occurs in the setting of erythrocyanosis, all due to the associated dysautonomic features of your lipedema patients. And here's one that is definitely overlooked. And when you ask the patients with lipedema to open their mouth, they give you this look, not uncommonly. I thought I was here to look at my swollen legs. Well, as you see here, what do you see here? A very high arch, narrow palate. Back to our diagnostic criteria for hypermobile Ehlers-Danlos syndrome, dental crowding and high or narrow palate. So another often overlooked feature that you see in your lipedema patient. Now, once you become cognizant of the fact that your lipedema patient has this myriad of clinical manifestations that are far beyond simple swollen legs, it helps you with your differential diagnosis. And here's a great example. If you're asked to consult on a 48-year-old female with bilateral lower extremity lymphedema, you're perusing the electronic medical records before you go into the room. And you note that the patient has migraines, flat feet, POTS, irritable bowel syndrome, chronic bilateral hip and knee pain. They've had 2 shoulder surgeries and even a rectoceal repair. So armed with that information, before Dr. Gasparis, even goes in the room with his associate vascular surgery fellow, he goes, I bet you this patient doesn't even have lymphedema. I bet they have lipedema. Think lipedema. And more often than not, he's going to be correct. Note the genu valgus deformity, a little bit of erythrocyanosis there. And then finally, the difference between lymphedema and lipedema. Here's 3 classic clinical differences. Lymphedema on the left, lipedema on the right. Lymphedema can be unilateral, it can be bilateral, whereas lipedema is always bilateral by definition. There is no unilateral lipedema, even though I still occasionally get referrals for that. Lymphedema, even when it's bilateral, tends to be a little bit asymmetric, as you see here, versus lipedema tends to be relatively symmetric. Lymphedema typically, although not invariably, is associated with swelling of the feet and toes, and lipedema is typically, although not invariably, associated with sparing of the feet and toes from swelling. And here's another consensus statement from the standard of care document. Women with lipedema over a period of time can develop secondary lymphedema, also known as lipolymphedema. And lipolymphedema is lipedema that's progressed to a clinically identifiable lymphedema or risk that increases concomitant with stage. So it's more likely in your latter stages. And it's also more likely in the setting of obesity. In contrast, the amount of foot swelling you're seeing here in a patient with primary lymphedema versus a relatively mild dorsal foot swelling in a lipedema patient. So I'll stop there and end my screen sharing.
Thanks, Steve.
Oh, you bet.
Question for you. Can you explain to the audience, what is it that, from a pathophysiology perspective, how does a lipedema patient progress to a lymphedema?
There's a lot of different reasons, Tony, but first of all, there's a thought that I think was not just a thought, but there is actually histological evidence. These patients have very leaky capillaries, and these leaky capillaries over a period of time lead to a dynamic lymphatic insufficiency, for instance, and that starts to cause fat deposition. But leaky capillaries, leaky venules, that's a role. Now, the obesity that they have also plays a role in developing secondary lymphedema, no doubt about that. As I suspect you're going to be talking on, they have associated venous dysfunction as well, that probably at some level exacerbates their lipedema. But fundamentally, I think it gets back to these leaky lymphatic vessels that they have, leaky capillaries. And not only that, there's MR evidence that if you look at even the larger lymphatic trunks, even in the absence of obesity, have tortuous, unusual, dilated, segmented lymphatics. They're not normal lymphatics, either from a microvascular standpoint or from a macrovascular standpoint. There's something dysfunctional about the lymphatics, irrespective of obesity, and that's been shown histologically and by MR imaging.
And someone's asking, is there any objective testing that you can get in these patients, or?
It's a clinical diagnosis, although Tom would tell you that ultrasound can be very helpful in looking at the tissues, both the dermis as well as the sub-Q, and there are differences between that and lymphedema.
Tom, you want to comment on that?
Yeah. And there's a paper out of Brazil in the last year that also says they can diagnose it ultrasound. But I think it really is, and I don't know, that hasn't been validated besides that author, but I think, it is a clinical diagnosis, but we do see, characteristic signs on ultrasound. I just don't, it's just not settled enough exactly what would be the criteria you'd use.
Yeah, no, I agree. I mean, it's mostly clinical diagnosis, although most of these patients do get an ultrasound, to rule out any other, venous disease that may be causing their leg swelling. But based on the clinical presentation and physical exam, you should be able to rule that out.
Yeah, especially those classic pictures that I showed you. Those are the easy ones. They're slam dunks.
Any genetic predisposition for this?
Yeah, about 40 to 60%, depending on which studies are going to have some genetic, are going to have a family history of lipedema.
Okay, and how about dietary?
Well, so actually, there's a couple. We recommend a low carb or low refined carb diets for all these people. Really help, and we. Many do a full ketogenic diet. Not every lady can stay on that, but even just a low refined carb will decrease insulin, which of course has a prominent role in fat deposition.
Okay, Steve.
Yeah.
Can early on use of compression garments or pneumatic pumps help delay progression to lymphedema?
I don't know that in a setting of lipedema, I don't know of any articles intuitively, I'd say it very well could, but I don't know of any objective evidence to state that's the case.
So actually, I have a paper that's been submitted for publication with intermittent compression and compression stockings, and we saw a decrease in limb size, decreased extracellular water, and decreased pain. But I can't say, we didn't follow these people. I don't know if it would prevent progression, but it certainly can, certainly can make things better.
Steve, you want to take this last question?
That's a long question to answer, but it's just, it's a fat deficit. Lung disease has a very characteristic phenotype. I would look at it where it's multiple symmetrical lipomatosis. They have a different phenotype where it's sort of the opposite. Their neck and their shoulders are very, very big and swollen. So it's sort of the opposite of a lipedema patient. They get a lot of fat deposition, even a horse collar deformity around their neck. It just doesn't look like lipedema.
Julie, any comments?
Well, I just think with the question about compression, I have noticed with patients that, of course, when they are wearing and, using sustained compression, that they're going to be moving more, they're going to be exercising more and losing weight. And so I do think that it could stop progression, but I don't have any hard evidence.
Oh yeah, and intuitively, I'm a firm believer of intuition, but yeah, I just don't objectively. We don't have a paper yet to prove that, but it makes sense.
What type of compression are you using in these patients?
Well, I am going to go over that a little bit
Okay.
after you speak about the venous aspect of it, and then I'll talk about conservative treatment. But I think it really varies on the patient.
Okay, and Steve, this one's directed to you about asymmetric presentation when there's impaired mobility.
I'm not sure what was not answered about it. As far as we're differentiating lymphedema versus.
Well, my experience is that there's mobility issue. Lipedema can be asymmetric.
Well, nothing's perfect. I guess it boils down to, how asymmetric are you talking about? Sure. You could have iliac vein compression on the left. Most lipedema is probably a little bit worse on the left, but it's relatively symmetric, I think is the term I used. Nothing's perfect, but.
Yeah, well, our body is asymmetric to start with.
Yeah, yeah.
All right, so I think we'll move along and my task is to cover what is the connection between lipedema and chronic venous disease. Now, some of these slides are going to look pretty familiar. Thanks to Steve here, who sent me this presentation. I modified it just a little bit, Steve. So I don't know if I can do as good of a job as you do with it. So feel free to, just take over whenever you want.
I'm staying out of this one.
All right, so this is the first question. If we can have a poll up. So identify the true statement regarding lipedema, and I think with respect to chronic venous disease. Let's see what the results are. Okay. Interesting. So correct answer is manifestations are more likely to improve than bilateral manifestations after GSV. And we'll talk a little bit about this as we go on. So what's really the connection, or is there a connection between lipedema and chronic venous disease? And you can see here on the left, patient with type 3 lipedema, and you have classic spider veins in the thighs. There's some varicose veins in the inner thigh, and there's lipodermatosclerosis in the ankle, in the perimalleolar circumferential almost on both legs. And the patient with type 2 lipedema here, pretty, typical lipodermatosclerosis in both lower extremities. So just looking at this, you would think, there is some type of association in these patients between lipedema and chronic venous disease. But when you look at the literature and the lipedema literature, there's really little to no or minimal discussion or data with respect to the association of CVI with lipedema. And this is one of the first papers that talks about it, and included 119 patients. In this group of patients, there was 9% of them that had saphenous vein reflux, 5% had chronic skin changes, and 2.5% had ulcerations. And when you look at the best practice guidelines on lipedema, there is a mention that patients with lipedema, they may have compounded effects due to underlying chronic venous insufficiency. And that in the advanced patients with lipedema, other causes of classic edema, such as chronic venous insufficiency, should be considered. Looking at the 2018 consensus on lipedema, there's a mention on edema associated with venous insufficiency, and that chronic venous disorders can be associated in patients with lipedema. So is venous disease in these patients causative? Is it coincidental, or is it additive, or a combination of the two? And in this paper here, patients with lipedema, a quarter of them had truncal reflux. Is that really show an association between the two diseases? Well, Joanne Lohr, in this paper, looking at venous disease in women, the incidence of superficial disease was 22%. So really not much different than the 25% in the lipedema population in this paper. How about breaking down on clinical classes? So C1 disease, or patients with spider veins and lipedema, in the consensus document, they consider that coexistence of telangiectasia is not a characteristic condition of lipedema, but rather a coincidence in patients with C1 disease, as this is pretty common, up to 50% of women. Karen Herbst, in her the definition of lipedema, or breakdown of what is really lipedema, under 11, as far as a classic finding, is telangiectasia. So a little bit still not clear cut as far as the association of C1 disease and lipedema patients. In her paper, though, here you can see, and the reason why she has it as part of the different of the findings in patients with lipedema, that in stage 1 patients, 100% of the patients had visible veins in the legs, while in stage 2 patients, 72%, and stage 3, 27%. So you can see a significant number of these patients have at least C1 or C2 disease, indicating potentially that there is some strong association, more than the 20% that is present in the population. In the earlier paper by Lester that Steve mentioned earlier, looking at varicose veins in those 119 patients, there was 35% of the patients had varicose veins. So a little bit higher than the normal population. How about advanced disease? So this is CVI, C3, 4, 5, and 6 disease. So these patients that we showed earlier, in a paper that Steve recently published of 440 patients, almost 50% of the patients had some form of venous CVI in this population who had lipedema and lymphedema. So a much higher percentage of advanced CVI in these patients. So looking at lipedema and CVI, there is a strong association from what it looks like, more than in the general population. So the question is, what really is causing this effect? And why are these patients presenting with advanced CVI? Well, one thing is, as Steve mentioned earlier, lipedema is a connective tissue disorder, and patients with varicose veins have also a connective tissue disorder. So they have an abnormality in the early theory of abnormal valves causing reflux, and the reflux causing venous hypertension. There's really shown data that there is an abnormality in the collagen in the vein wall as well as the valves, and that abnormality leads, connective tissue abnormality leads to dilatation of the veins and reflux in the valves. So the lipedema patients are predisposed to varicose veins potentially and incompetent veins because of this tissue, of this connective tissue abnormality. Similar to what he mentioned earlier also with the Ehlers-Danlos syndrome, another characteristic in this group of patients is that they have varicose veins at a much younger age, and this is also a connective tissue disorder. So maybe there is a stronger association of development of CVI in patients with lipedema due to this connective tissue disorder. The other problem with these patients is they have a significant high BMI, anywhere from 38 to 48 BMI in this population, which also can contribute to CVI. And the pathophysiology behind that, or the mechanism through this, is because of outflow obstruction in the iliac and common femoral veins due to the pannus and obstructing the venous outflow. You have pro-inflammatory state. There's decreased movement in these patients due to the increased weight, and they also have potentially popliteal venous compression due to the pannus there. So there's obviously a combination of connective tissue disorder with the vein wall abnormality and obesity mechanisms that both together can be leading to significant venous hypertension and development of CVI in these patients. So how do you treat these patients? Well, obviously the typical treatment for venous disease includes compression, maybe some venotonic drugs, and depending on where the disease is, you may even consider treating the superficial system or deep system if there's venous outflow obstruction. But the question is, just because they have venous disease, is that going to really treat their underlying problem? And most of the situation, these patients, lipedema is the predominant problem and not the venous disease. So you need to thoroughly discuss expectations, because if the expectation is that their swelling is going to improve or their lipedema swelling is going to improve, that's not the case. Like I said, most of the times it's the lipedema that's the predominant problem as far as their limb swelling. So when it comes to limb swelling, treating a saphenous vein with reflux is not going to really fix an issue in these patients or improve their symptoms. So some things to consider when treating these patients, that size and the shape of the legs is not really going to improve. there's not going to be any improvement in the lobules that they have. They may have some modest improvement in their pain and heaviness in the leg. And this is important, again, to get a good history and physical in the patient. So if they're clinically symmetrical, but they have more heaviness or discomfort or pain in the one leg, and that's the side where you find saphenous reflux, for example, then maybe, and there's an indication there for treatment just to improve their pain. But if, like I said, if it's the swelling you're trying to get rid of, that's not going to be helpful. As far as the skin damage, again, if there's symmetrical skin damage and there's only unilateral disease, then maybe the skin damage is not related to saphenous reflux, and there's other issues going on, such as obstruction from the pannus. But regardless, if you have a pretty significant saphenous disease, it may consider treating these patients just to prevent progression because of their significant reflux. So pretty much we usually try to avoid intervention in patients with lipedema and mild or moderate superficial disease because it's not unlikely for them to actually get worse after treating them. So after ablation, if you destroy the lymphatics, you may get worse swelling because of that. So be very cautious to offer therapy in these patients, and be selective in those who may benefit, for example, preventing further skin damage or developing a venous ulcer. So in conclusion, lipedema and venous disease is common and underreported in the literature. It's more common than in the general population. So the thought is that there is an association between the two, that CVD underlying characteristics of skin changes that they get. Pathophysiology is a combination of vein wall weakness and their underlying obesity, leading to venous outflow obstruction. And interventions, really, you got to be, have appropriate expectation on the patients, see what exactly they're seeking treatment for. And if it's for their swelling, usually we do not intervene for that. But if it's for heaviness or pain or skin damage or ulceration, then there may be an opportunity there to improve their clinical symptoms. And I will stop at this point and open up for discussion.
I just have a question. Do most early stage lipedema patients come to you for pain, or is it swelling, or both?
It's both.
It's
I think
both.
Yeah.
So do they often, not knowing that they have lipedema, think that it is associated with venous disease or coming to you?
Absolutely. And then what happens is that it's not an uncommon scenario where you'll see patients that have had these four saphenous ablations, and they've had both their great saphenous vein, both their small saphenous veins ablated, and more often than not, they're universally disappointed, and they don't even have a diagnosis of lipedema. It has been that, and I'll see them in consultation and go, "Oh, well, you have lipedema. That's the problem here." And they were told that things would get better after the procedure, and it's half the time I'll say there was no improvement. Half the time the pain does get a little bit better, and about half of that time it's transient. The other half of the time it does seem to have some permanent improvement. But Tom's a great resource on that, and Tony, I would think too, because you see these patients who perform procedures. I don't. I just see them after they've already had their procedures.
No, I can't tell you how. At least daily, I have someone who presents, and they think they're there because they think it's a vein problem, and it's not. Their veins are They may have mild vein problems, but the real pain is from the lipedema.
I mean, the key here is, like Steve mentioned, lipedema is a bilateral disease. So if both legs look the same and their symptoms are the same and they have unilateral disease, then you're not going to help them. If they have, they look similarly from a lipedema, with the ankle cut off and they look classically like lipedema, but let's say they have unilateral disease, which is different than the other leg, and they have big varicose veins, that patient you may improve as far as their heaviness, discomfort. But if it all looks like lipedema and they have some venous disease, I would be careful as far as treating them. Or if they have, let's say, C4 disease on one side, but they have, the other classic findings of lipedema, and they have a 9mm saphenous vein, that patient I may offer treatment just because they're declaring themselves that clinically the one leg looks different than the other, and that's not typical for lipedema patients. So then I can assume or come up with the conclusion that their venous disease is what's causing their skin damage.
I would just add, if they have really big, big ropey varicose, really large, and they're tender at those large, then you're going to help them. And so, I think that's the only other thing I would add to that. Thank you.
Okay, should I get started then, or do you have other questions in the Q&A?
Yep.
Julie Green time. Yeah.
All right, so I am just going to do a brief overview of conservative treatment for lipedema patients. Obviously, this is a really complicated condition, and it really requires a holistic approach, and I think that really is supported by both the US and the European consensus documents. Goals really would be including reducing pain, swelling, improving mobility, improving the patient's quality of life. Treatments should also consider providing resources for emotional and social impacts of the disease. There's quite a few local support groups out there now, but there's also support groups on social media, as well as national resources such as Learn, the Lipedema Project, and the Lipedema Foundation. And these really are great for patient education. They provide webinars, they provide resources and support. So treatment options include surgical interventions. Dr. Wright's going to go into that a little bit more in depth, but more conservative would be complete decongestive therapy, dietary recommendations, exercise, or some type of physical activity, and emotional support. FlexiTouch, advanced pneumatic compression, also does play a really key role for these patients in helping address pain and maintaining their activity and any reductions that they would have achieved in their therapy sessions. So a referral to a dietitian for nutritional guidance may be recommended for patients, along with maybe a blood panel to check hormone levels and any vitamin deficiencies. The patients may have lifestyle factors are huge and can make an impact on this population. And just like Dr. Wright said, there's no specific diet, but they tend to do well with anti-inflammatory diets or the ketogenic diet, which is low in sugar and carbs. Patients should be made aware of important functional movements throughout their day, and really programmed exercise programs, therapeutic exercise. This will often really focus on postural components and core strengthening, along with instruction on proper diaphragmatic breath work to increase lymphatic fluid absorption. And for optimal home exercise programs, maybe yoga or reformer Pilates, walking, riding a bike. I think one of the most common exercises recommended is aquatic therapy. And especially for patients that have advanced stages, they often have significant joint pain and limited mobility. And in the water, they can really move pain-free. And the hydrostatic pressure also provides that natural gradient to increase lymphatic propulsion and circulation. So there are several causes for the development of fibrosis. I think they were covered a little bit here in patients, but this is a challenging thing to treat for patients just due to the sensitivity and pain that they experience. And I think that when patients are experiencing that first episode or that first treatment with anti-fibrotic techniques, you have to go a little bit slow and gradually increase to their tolerance. They can really benefit from breaking up that fibrosis and really addressing trigger points. And they do get pain relief if they can, build up that tolerance to some of those techniques. So CDT or decongestive therapy is also really important for this patient, just as it is with lymphedema and lipolymphedema. Really addressing the main goals in clinic are going to be, reduction of fluid volume, improving the tissue health, reducing fibrosis, and getting them ready, educating them on what their condition is, making sure that they're competent and have ready compression garments and tools that they can be successful in their home program. And then when they are discharged to home, that is their phase 2. And basically they're going to try and maintain any reduction that they've achieved and work through a home program that is provided. So compression, it is really individual for lipedema patients, and it's kind of tricky because you really have to work within their tolerance. I mean, they're hypermobile, so oftentimes it's not the fact that they can't reach down to put their stockings on. They just are so hypersensitive to pain that certainly circular knit compression stockings aren't great for more advanced stages, especially because of that ankle cuff. It really tends to cut in, cause a tourniquet effect, and cause quite a bit of pain. And so obviously if patients are in pain, they're not going to wear their stockings. So you have to really work with the patient, with the DME, making sure that you find the right fit. Sometimes patients will need to overlap and use layers of compression, working towards something that is just going to work within their day. And here is a guide that was published in the US consensus document, and it just gives you some actual compression grades that are typically more appropriate for lipedema compared to lymphedema patients. They tend not to be able to handle those stronger compressions, although it is nice if we can get them into a custom garment if they do have, lipolymphedema, because they really need the structure and the strength of the fabric to contain that swelling that's going to occur throughout their day. And you can look at that guide. And then here are some options that you have. These are very common for patients to use. The ones on each side are the micro massaging fabric, and they come in knee high, they come in capris, they come in pantyhose. They even have some tank tops for patients that maybe have truncal or arm involvement. They have arms that, and then they have like a panel around the back. So maybe some of those would work for patients with upper extremity lipedema. And the other thing about them, you can still utilize overlapping with other garments if you need to. And the nice thing about these is also you can wear them at night to really contain. So the idea is to provide support to those structures and the tissue to, try and get a good shape of the limb. And oftentimes this is going to just really help them move more, relieve pain, relieve some of that aching. The other items on here, the Solaris Ready Wrap is a nice alternative for patients that really struggle with wearing a pantyhose or have trouble donning a stocking. And they can also be adjustable, so patients can use them, a little tighter when days that they have less pain and looser when they have more pain. And then the last one is this knee-high expando sock, which is great for patients that have really large calves. They actually go up to 60 centimeters or 24 inches, and that could be worn over the capris or the micro massage fabric garments that you see here. And then the FlexiTouch, as I said, it's really a key tool to be able to help these patients manage. And if the patient is benefiting from manual lymph drainage in clinic, they're certainly going to benefit from an automated manual lymph drainage treatment at home daily to really reduce that lymphatic burden, keep that maintenance and tissue fluid lower each day that they wake up. It's an hour treatment. They can manage it in terms of pressure settings, areas that they maybe are tender, which, as we know, lipedema patients have areas of tenderness on the medial knee and the lateral hips. So you can reduce the pressures in areas that you need it. If they are a combination where they're lipolymphedema, then you can increase it in the foot if they have fibrosis, and then reduce it as you go proximal up to the trunk. And then you can have supplemental programs, addressing challenging areas or avoiding areas that are just too painful. And that is it. Any questions?
Thanks, Julie.
Yeah.
Very nicely put together. I think a lot of good information here. Any questions, Tom or Steve?
No, that was,
No question. I think it's interesting, Judy, what in your experience, we always talk about the flat nets being much more comfortable, much more tolerable when they clearly are, but it's just a matter of how many insurance companies will actually pay for flat nets because they're so expensive.
I know they are. And there are some off-the-shelf flat nets also.
Oh, really? Okay.
Yeah. And they're it's made by Solaris, and it's called an ExoSoft. And so you can order those. They are more expensive than the circular net, but that's, I think, where you can play around a little bit with your patient to, try how are they managing or tolerating the bandages? How are they, and kind of work with them in less expensive garments to see how they do tolerate it, and then just encourage them. I mean, it makes such a huge difference in holding and supporting that limb that I think if you can encourage them that, you're going to have less pain, you're going to be able to move easier. You're going to just be able to manage your condition better if you can invest in something that you're going to wear, right? I mean, if it hurts, you're not going to wear it. So
I can answer about the vibration plates. They are, it's 18 to 22 megahertz this is, seems to move lymphatic fluid. And some people swear by them. This has not really been well studied. And then I also just want to, Julie, thank you. That was great talk. And then I think I want to, and there's another question about, can we get these people to wear, lipedema patients really do benefit from compression. And I really try, to get, if they're stage 2 or more, I try and get them at least 20 to 30 graduated. And there's so many other, I may have mentioned you do get some limb reduction, but you get anti-inflammatory properties. It helps contain lobules. There's so many other positive things. They're a pain, and they're not well covered, but they really do help lipedema ladies.
Julie, how much reduction would you expect in lipedema patients receiving MLD?
That's really depends. Obviously, if they are pure lipedema patients, really expectations have to be set that you may not see, you'll have minimal reduction, but you might have improved function, improved ADLs, less pain. So I think you kind of talk about it in more functional improvements. And as well with the FlexiTouch, right? So we always set expectations with our lipedema patients that you may not see big reductions, or you may never have large reductions, but it will help with all these other components of your condition.
Yeah, unfortunately, that's the case in even in venous interventions. When you have somebody with leg swelling, swelling in itself is always a very difficult clinical sign to improve even after venous intervention. So the leg may feel better, the quality of life may improve, but they may still have swelling in the leg. So it's kind of similar with the lipedema patient, I think, too. Now, you mentioned the FlexiTouch. What if they're not covered? Can an entry be used in these patients? That was one of the questions.
Can what?
Oh, the
Entree
entree.
device?
They want to know if the entree can be used.
Oh,
Entree.
an entree. I would say that most lipedema patients may not tolerate an entree. It's certainly worth a demonstration because I think it varies from patient to patient, but I would say that because most of our patients that utilize the lipedema or the FlexiTouch, we tend to reduce the pressures.
Mhm. And what are the
There is a
criteria?
low pressure on entree, so it's certainly not out of the question.
And what are the criteria for coverage? Do they have to fail other type of treatments or?
Well, sometimes you have to go through the basic pump failure if you're looking to get the FlexiTouch.
Okay.
And I always encourage clinicians to always document, and make sure that you have all of the functional problems that the patient is experiencing.
What's the pressure that's used in the flexi in the
Oh,
lipedema
I think
patient?
oftentimes in the low, it tends to be around 20 to 30.
Okay. Steve, if the pathophysiology is a connective tissue disease, how does really compression help? Oh, I see you're typing that answer.
Yes, I have an answer. I'm not really quite sure what compression better than what. I mean, you're still going to treat the edema regardless of if there is a connective tissue. I mean, the edema is just one manifestation of the lipedema. So compression has benefits in that scenario. I'm not sure they're mutually exclusive problems. I'm not sure how to answer that.
Okay, there's a bunch of more questions. We'll answer some of them as we're going along. Why don't we get Tom
Okay, Tom. Yeah.
to kind of wrap it up for today?
All right, I gotta move this out and then, yep. Okay, yeah, thanks. So I'm talking about lipedema surgical treatment, and Tactile Medical has sponsored my research. I think I mentioned the research on compression and intermittent pumps in lipedema. So when there's lots of surgical treatments for lipedema, but I'm going to be mostly focusing on lipedema reduction surgery, which is basically a derivative of liposuction. But there's also manual extraction of lymph nodules and removal of skin. So when to consider surgical treatment? After conservative measures, including graduated compression, weight loss, and manual lymph drainage, and most will benefit from an intermittent compression pump. So after those conservative things have done, now who's a good candidate? This is variable. Obviously, lipedema by itself increases BMI. So it's a separate fat disorder that from lifestyle-induced obesity. So they tend to have higher BMIs, but certainly at when you get to about BMI around 50, there's a greater, 90% of them have some secondary lymphatic insufficiency just from their obesity or that kind of a lipolymphedema. So, I will in the larger BMIs, I will when they're getting over 50, and there's some variability, but we'll refer them maybe for bariatric surgery first. Waist to hip ratio, though, is a better measure. And if their BMI is in the high 40s or even low 50s, but their waist to hip ratio is less than 1, then then really most of their weight is in their legs and hips, and so they're going to benefit greatly, and so maybe you're going to be a little higher on the BMI. Obviously, we want them diet compliant, or at least with weight loss, at least weight neutral or with weight loss is recommended. Julie talked about the diets we recommend. Compliance with compression is really critical, because when you do this surgery, you're going to actually increase the swelling in the limb short term, and they really have to be compliant with their compression post-operatively. Well, how do you know if they're going to be compliant with post-operatively? Of course, they have to be able to wear it preoperatively, and overall good to fair health. So liposuction is one of the most common cosmetic procedures. And so liposuction is focused on optimal fat removal and derivatives of, I'm going to move this over. Well, it's fine. I'm going to back it up now. Sorry, guys. Liposuction is focused on optimal for aesthetic results, and then derivative of liposuctions are increasingly used for the treatment of both lymphedema and lipedema. So lipedema reduction surgery is not the same as lipo. It is using the same kind of tools, but it's focused on pain relief and functional improvement. It removes much larger volumes. 5 to 12 liters of aspirate is pretty typical, whereas a cosmetic liposuction will be 2 or 3 liters total aspirate, and it's performed obviously on larger patients. Your average lipedema patient has a higher BMI. There's larger areas of treatment, so what would be considered cosmetic surgical areas, we're often treating 4 or 5 cosmetic surgical areas in one lipedema reduction surgery. And it's a much longer procedure. Average total procedure times 4 to 6 hours, whereas a cosmetic liposuction is 1 hour or 2. And then there's measures to protect lymphatics should be realized. And we're not just removing fat, we're removing fibrous tissue and extracellular glycosaminoglycans. We are debulking all the tissue, not just the fat. And so multiple case studies have shown that it can improve gait and stance, reduce pain, reduce the need for compression in MLD, and can reduce, and that's a typo. It should be halt progression. So those studies are well known, but I have some new stuff using RAND, which is a patient reported outcome. RAND SF36 is multiple patient reported over multiple health domains, and also PROMISE, which was a NIH developed tool of patient reported outcomes. And these are studied in all sorts, kind of apply them to, compare them to other diseases, how effective the lipedema reduction surgery is compared to other surgical interventions. So this is from my practice, and we, preoperatively we administered the RANDS surveys, and so they start. Your average lipedema patient presenting in my office starts with about 2 standard deviations below normal in terms of physical functioning. Energy and fatigue is significantly reduced, and this is compared to the normal population mean. And these are all normalized, like Z-score or T-score values we're looking at. So obviously, And then after the reduction surgery, and these are usually administered about 6 weeks after, you're seeing significant improvements in physical functioning, role functioning, energy fatigue, pain, general health. And this is that same data, just graphed, and so sort of the normal is going to be is kind of runs below normal, and most of these measures is below. And then I'm going to back up one. Hold on, got to back up a couple. And this really, these kind of changes, seeing a 1 or 2 or 3 standard deviation improvement this is better than, say, the kind of outcomes or improvements in physical functioning seen with like spine surgery for low back pain and that sort of thing. And then looking at the promise, we're seeing, these are just questions, of 15% increase in ability to walk, 18% up and down stairs, 15% in ability to get from the floor without help. These 17% able to run short distance, et cetera, to catch a bus. And so you can see, these are significant, improvements in overall quality of life. Now, if you compare the PROMIS data that we have, we're seeing an average increase of 10 points in mobility. And for example, so 2 to 3 points is considered minimally clinically important change in healthcare. And a knee replacement is going to give you a 3-point or a 5-point improvement on those same using those exact same measures. We also see mechanical improvements after lipedema reduction surgery. So this diagram just shows this is how we measure knee flexion, which is, and we're seeing an average 8-degree improvement of knee flexion or knee range of motion after the reduction surgery, 8-degree improvement in valgus rotation of the knee, and Steve showed a picture of how that occurs, and 2.7 degree in Q angle, and 84% of patients improve their gait. Lip reduction doesn't need lymphatic protection. So lipedema patients have impaired lymphatic function, and they are at increased risk. And so extra care should be taken not to damage the lymphatics. Now, this is what I do, and not all people treating lipedema do these measures, but I do a preoperative venous and mapping with map venous and lymphatic structures. I use small cannulas. They're always blunt. Longitudinal technique, multiple positions around. I mean, the patient is moved through a whole 360 degrees of positioning through the surgery to get for optimal orientation. Now, this is just a case report, and this patient had lipedema reduction, and then she had a complication, developed lymphedema in her right foot. And this is just the lymphoscintigram, and you can see it was not immediately recognized. It took about a year for her to accumulate this, and you can see the lymphoscintigram did support the diagnosis of lymphedema that was caused by liposuction on a lipedema patient. So let's talk about insurance coverage. So it's, many or all of the insurance policies are contradictory. For example, like it has to be severely impairing their mobility in life, et cetera. But then they have to be UHC says they have to be under a BMI of 35. Well, it's usually in the BMIs of, larger patients where it's really impairing their ability. And there's it's always coded with a cosmetic code. For example, 15879. Now, this is a cosmetic, there is no CPT because CPT is AMA and there's no official code. There's no official description while the code is there as a placeholder, as a cosmetic code, it doesn't have an official description. There's no RVU assigned to it. And when you find any kind of description or definition or whatever the insurance, it's not describing the time, work, or skill, because it's describing a cosmetic procedure that's an hour or two that is done in people with BMIs around 25 who have no increased risk for lymphatic injury and no lymphatic impairment, these sort of things. And there's huge variability in reimbursement. It's completely up to the carrier. So that because there's no RVU or no official description, they can pay whatever they want. And so, I mean, the range of what they will pay for this, 4 to 6 hour surgery, it varies between $160 to $15,000. And it's crazy. You can't even, and most of the time it's on the much lower end. So it's really quite erratic and unpredictable. It's very variable. So that's it. Thank you for your attention, and thanks for helping spread the awareness about lipedema for Lipedema Awareness Month.
Thank you, Tom. Very nice. Obviously, like you said, not something that's done often from plastic surgeons because it's more of a medical procedure rather than a cosmetic procedure. Our plastic surgeons here don't offer it for lipedema patients, mostly for cosmetic patients. So it's good that this is an option for some patients, and obviously more education is needed out there and awareness as far as this being a therapeutic option for them.
I'm sorry. I was going to say that the plastic surgeons that do lymphedema surgery typically will do the
correct
reduction surgery.
Yeah. Any questions?
I've got this question. Tom, is there any way of determining who is going to develop secondary lymphedema after liposuction in other anatomic areas like their abdomen or their breast? Because I've seen a lot of frustrated patients after liposuction. They paid all this money and their legs are better, and then yet they come in, they say, now look at my arms, look at my chest, look at my abdomen, it's more swollen after liposuction. Is there any way ahead of time you can prognosticate who's going to get this side effect?
Well, so there may be two different things there. So it could be, so Karen and I published a paper about the surgical. So some people get growth of lipedema tissue in other areas if they have it. If they have it reduced in their legs, they might get it new in their arms or breasts or abdomen and so so we see that more in the U.S. than is seen in Europe. We also have more obesity, and we have, so there may be a lifestyle thing at play, and maybe the other part is maybe it was always there and it just got a little worse. But it could also be, but there's no. The only way to predict for at least for that subset that are going to get worse or is, if they're very good about, I think they do better if they have a very good diet and exercise and conservative. If they still adhere to the conservative things, I think they're less likely to do that.
But you can't prognosticate ahead of time unless you just, okay.
Yeah.
I'd like to point out, there's quite a few questions on here about diagnosing Ehlers-Danlos syndrome from a genetic standpoint. I do want to point out that the lipedema patient parallels the hypermobile Ehlers-Danlos syndrome patient, there is no genetic test available for that, period. And the patients will ask you, and they'll come in and say, I want genetic testing, and you have to go explain that to them. This is not vascular type, it's not classic type, it's hypermobile type. Of the 14 subtypes, it's the only one there is no genetically available test. They know what the gene is, it's the tenacin X gene, but it's just not commercially available, period. And it's a clinical diagnosis. Get out the one-page sheet. You just get online and query hypermobile Ehlers-Danlos syndrome. There's a one-page handout, the one I showed you, and it's got all the boxes you can check off. And you can create a smart phrase with it. That's what I've done on my patients.
There was a question earlier that Steve, you answered. I just want to touch up again. There was a question on how do you educate, or how do you get the word out to vascular surgeons that are doing vein procedures on these patients that they may be causing harm to patients. And, especially when they come to you and they have persistent swelling. So obviously one thing is educating them. If you're seeing a lot of lipedema patients and you have an expertise and interest in lipedema, reaching out to the community of vascular surgeons that are treating these patients and provide some education is very important. But obviously these patients have other cause of their swelling. So offering treatment to them with either compression, pneumatic pump, or really treating their underlying problem rather than burning a vein that was normal. Let's see, there's a bunch of other questions.
Somebody asked about ICGL imaging. The problem is ICGL imaging is not readily available. It just isn't. And even though there's really nice studies from Eva Civic's group, and it's the camera they use is not on the market yet. It's not. And not that you can't get ICGL, you can, but it just, the one that's commercially available really just looks at the superficial lymphatics. It's not very helpful otherwise. And it's certainly not helpful for lipedema diagnosis. But hopefully when this other camera comes out, that'll change things.
Tom, with respect to the liposuction procedure, you mentioned earlier that they have a decrease in use of compression or MLD. Are there studies, or is this based on your own?
No, so there's actually 3 studies, Baumgartner's group, as well as Stefan Rapprich, and they showed that they needed less. So the patients they followed needed compression to use less often, or about 30% didn't need it at all afterwards. So a third still needed it, a third needed it less, and a third didn't need it at all.
And was that study, did it talk about what stages those patients were at, or?
They were mostly stage 2 patients, but yeah.
There was a question.
I don't know exactly. I'm going to say that's just my recollection of the papers.
So based on your experience, though, I'm curious about your own patient population. And
I would say I say that's pretty accurate.
Okay.
I would say that is I would say 2/3 need it less or not at all.
So there was a question on how do you get reflux documented on patients that have severe lipedema, because of the size of their legs. How do you augment in order to document reflux? Again, you're right. I mean, with obesity and especially with the lipedema patients having pretty large calves, it's difficult for a technologist to document reflux on their own. Usually we will have a second person come and use both hands to augment the calf and squeeze the calf in order to evaluate for reflux. So it's a challenge with anybody with large legs, not just the lipedema patient.
Yeah, then you'd have to wonder, Dr. Stanbro, whether or not you should be doing a reflux on a really, really large patient. I mean, how much is that reflux really playing a role in their swelling?
I think, these patients have a pretty classic looking for, C4 disease. And, where, even if you find superficial disease, I find that it's more their deep venous obstruction due to the size of the penis that's really leading to venous hypertension. All right, any other questions? The rest of them are kind of, and we're a little bit over time. So when are we're going to close it off here.
Yeah, my fingers hurt from typing.
Finish your typing while I'm giving
No,
you
no, I'm done. I think
my closing remarks.
great question. This is I love the questions. These are all highly.
Yeah, we can be here all night.
So there-
questions. Yeah.
I just take a quick stab at, so there are only, I don't know, maybe a dozen doctors that are really focusing on lipedema around the country, and they're scattered out throughout the country. There's a couple up east, there's a couple out west, there's several in the Midwest, and then, unfortunately, there's, that's, you almost have to just kind of look around. There is the Lipedema Foundation has a locator for both therapists and surgeons that are treating lipedema. So.
Thanks, Tom, for that. So I'd like to thank everybody, Steve, Tom, Julie, really great presentations. I'd like to thank the audience for attending, and obviously Tactile for putting this together. And obviously, like I mentioned in the beginning, this is Lipedema Awareness Month. Get the word out and let's educate as much as we can.
Thank you. Have a great
Thank you,
night.
everybody.
Thank
Have
you,
a good night.
everybody.